oneself and not attack our own structures. And this is self-tolerance. So when we're in good regulation, this is what we can see with the Tregs. We're using anti-inflammatory cytokines and have this intrinsic tolerance. But then actually we can lose this tolerance, and often that is environmental factors or psycho-emotional factors, and we can then move over into the autoimmunity. We have more of the pathogenic autoreactive T and B cells, pathogenic innate immune cells, and the pro-inflammatory cytokines. Let's use the German at the bottom there. Okay, so how do we monitor all this? So people come in with a chronic illness and they're interested in doing the microimmunotherapy. So the first thing we do, apart from taking a history, is we do the lymphocyte typing. And this is where we look at the subset of lymphocytes. We're also looking at viral serology. So this is the baseline test that we do for people before microimmunotherapy. Because when we have these reactivated herpes viruses, this is the typical scenario. We test the 4 key herpes viruses, EBV, CMV, varicella zoster virus, and HSV1/2. And what we've found through experience and research is that when the immune system gets knocked for whatever reason, life stressors, toxicity, medication, and then we have this reactivation of these particular herpes viruses, the viruses actually block the immune system further. So we have this vicious cycle, this double whammy. So we really do need to address these viral reactivations to bring the immune system back up to balance. Protein profile, actually that's old, we don't actually do that anymore. But the inflammation profile, this is also really helpful. So the lymphocyte typing and the serology is what we need to do at the beginning to help us to put together a microimmunotherapy program. But the inflammation profile and the T helper cell profile, these are far more sensitive markers, so that as you go through your microimmunotherapy journey, which is often a year, maybe a bit less, maybe more for others, we can see the inflammation profile and the T helper cell profile changing more readily. You know, you can do it at the beginning, you do it 6 months, do it 12 months, whereas when you just do the baseline lymphocyte typing and viral serologies, this can actually take years to change. So if someone can, because obviously private medicine costs money, but if someone can, we recommend doing all 3 of those tests if possible. Okay, so in terms of mechanisms of action, microimmunotherapy, it is a low-dose immunotherapy. It's an immunotherapy aimed at regulating the immune system through the use of immunomodulatory substances in low doses. You can see the high doses, this is pharmaceutical level, and then we have the low and ultra low doses, which is microimmunotherapy. So it is gentle, it's really minimal side effects, if not no side effects actually. The reason I said initially minimal is because actually sometimes super sensitive patients, it can kind of bring out their existing symptoms. So then we have to do a more dilutional approach for them. But it's targeted. And actually when I started using this 3.5 years ago, it's been a real game changer for my practice. And you'll see a bit later a grateful patient, his testimonial, and actually it was my first ever microimmunotherapy patient. I was like, wow, this stuff's amazing. So it really does, it's had a big impact on the way that I practice. So yeah, mainly cytokines. These immunomodulatory substances circulate naturally in the body in these sorts of concentrations. And microimmunotherapy uses similar concentrations or even lower physiological concentrations. And basically what we're doing is we're mimicking the body's natural processes and improves treatment tolerability. So quite often people will be sent to me when they're not tolerating their supplements. You know, they're not tolerating their foods, but they're not tolerating their supplements. So functional medicine practitioners just don't know where to go with them. So microimmunotherapy is a really nice way to say, let's start to nudge the immune system back towards its healthy blueprint so you can tolerate better. So it has been going, you know, the work up to this has actually been many decades. 70s, 80s, this is when they first started the first attempts at microimmunotherapy, using nucleic acids and cytokines, but then actually this got expanded using specific nucleic acids, as we'll see in a moment. So cytokines, cytokines are there for immune signaling, so they're proteins that do the communication between immune cells, and they elicit regulatory functions both on the local and the systemic level. There are different types of cytokines which can have different actions basically. And this is just a nice little kind of graphic of the, summarizing MIT, we call it MIT, microimmunotherapy. So it's low doses, immunomodulatory substances, it has an action on the overall immune system with multiple objectives, which you'll see in a moment. It utilizes nucleic acids. It's sublingual administration, so it actually works on the capillary level of the oral mucosa, and it's sequential signaling, which we'll see in a minute. So some people, we have likened MIT to homeopathy, but this likeness stops at the dilutional process. So it's a serial kinetic dilutional process in vertical shaking like homeopathy. But it's, like as you see, we respond to the blood tests. So we do that first of all if it's working specifically on the immune level. And how it's formulated, it's mostly from plant proteins, and they use bioengineering basically to produce these immunomodulatory substances. Okay, so there are a lot of different complex formulas within microimmunotherapy, and it works on different levels. And when we have these ultra low doses, this is what does the down regulation of the immunomodulatory substances like the cytokines. And when we have the low doses, it's the upregulation, which you'll see in a moment. And somewhere in the middle, that's how we maintain things. And it's utilized in the hormetic effect, just like in homeopathy. So low dose stimulation can have this beneficial enhanced effect, and higher doses can have this more inhibitory effect. So this is the sequential signaling I mentioned. So this is how the microimmunotherapy comes through in these blister packs, labeled 1 to 10. You start at 1, end in 10. And it's basically in order to transmit sequential information. Much like the immune system works, I would say we're mimicking the natural immune processes. And the repetition of the sequencing over time is there to be able to enable the immune system to regain and sustain its own capacity for self-regulation. So this is why we have to do it over quite a long period of time, basically so that the immune system gets the message and carries it on itself. So yeah, so as I say, the immune system, it is a fine-tuned set of events, and that's what we're mimicking here. And we have this process of recognition, cell activation, neutralization, and elimination, leading to regulation and homeostasis. So these are the specific nucleic acids over here. So they are short single-stranded oligonucleotides from DNA or RNA, and there are different, depending on the target that we're aiming for. Tells us about the different objectives. So if this is self gene, this is about counteracting the dysregulation of the expression of certain genes and to treat the associated alterations. So for example, hyperreactivity, immunodeficiency, or an uncontrolled cell. Or whether it's an infectious agent like a virus, and it's about blocking the pathogen's infectious capacity, its growth or its replication. And then DNA, RNA, antigenic substances, and they induce the secretion of inflammatory cytokines and stimulate the immune response without over-activating it. Okay, so now just a bit about the basic formulas. MyReg, this is about mitochondrial regulation, and basically everyone starts off with MyReg. Most people, sometimes there are reasons why we don't, but most people start out with that sort of basic formula. It dampens excessive inflammation, reduces oxidative stress, regulates the immune response, optimizes mitochondrial function, and balances cellular energy metabolism. So you can see why that's going to be a baseline for most people. And it's just really to give you an idea of how the MIT is working. So we have the upregulation of certain substances and the downregulation of other substances. This is how each MIT formula is created. And obviously these are, this is an autoimmunity presentation, so looking at what we'd be using within autoimmunity. ARF is a common one we would use often for joint and musculoskeletal issues, but particularly joint inflammation. So we're inhibiting pro-inflammatory pathways and limiting tissue damage and loss of function, and avoiding that transition to chronicity. So you can see here, it's all just down regulation of cytokines and SNAs. Another really common one in the use of autoimmunity patients, we'd be using Inflam. So it's like it's our anti-inflammatory formula. So inhibiting pro-inflammatory pathways, stimulating the anti-inflammatory pathways, and counteracting harmful metabolic effects of chronic processes. So you can see we've got some upregulation, some maintenance, and some downregulation happening here. So very often when we're looking at the lymphocyte typing of an autoimmune patient, we will see this lymphocytosis, this hyperreactive picture, and EAI is what we would then start out with, which we can do alongside IREG and other remedies too. We do a maximum of 4 remedies per day, and the EAI bring down that lymphocytosis, and this is how it's doing: upregulation, maintenance, downregulation, dampening the inflammatory cascade, limiting the development of autoreactive B lymphocytes, limiting the production of autoantibodies by activated B lymphocytes, limiting the overexpression of HLA-1/2 molecules involved in presentation of autoantigens and the activation of T lymphocytes, and promoting immune tolerance and limiting the survival of autoreactive B lymphocytes and the production of autoantibodies. Not every autoimmune patient has this lymphocytosis, but it is quite commonly seen. And actually, even if it's not an autoimmune picture, if we see that lymphocytosis, we will start with the EAI. So, as I mentioned earlier, we do the viral serologies, determining the microbial burden that could be really impacting on the immune system. So we want to try and identify that if we can. So I always talk to people about MIT as it's a supportive process. You see it kind of coming up to support the system, but then we need to look at what the kind of ton of bricks is that's coming down on top of the immune system, and often that can be psycho-emotional, but it can be pathogenic, so we really do need to address the pathogens as well, and the psycho-emotional. So just to give you an idea, certain pathogens associated with specific autoimmune diseases. So this is just a selection, just to give you an idea. So rheumatoid arthritis, we have these certain pathogens. SLE, these specific pathogens are associated. And MS, someone was asking me at lunch, these are these certain pathogens as well that we can test to help to address that kind of that ton of bricks on top. And then you can see here there's a study here relating EBV to MS. Since COVID, we've seen a lot of EBV reactivation actually. So I guess that's part of that, a new hit, allowing for a reactivation of a virus, a herpes virus. Okay, so here is an example of one of the viral remedies that we use. So EBV for Epstein-Barr virus. So if we see this highly reactivated EBV on the bloods, then this would be part of the program. Normally what we do is 2 to 4 months of maybe even 6 months sometimes in severe cases, but normally 2 to 4 months where we do stabilization of the immune system before we start to address the viruses. And actually I always have a little review, just a 15-minute call with someone before we move on to the viral treatments, because if they're still in quite a weakened state and then you suddenly go in with the viral remedies, they can have a bit of not a reaction, but their symptoms can be a bit worsened, so they're just not ready to address the viruses yet. So then we need to do more stabilization. Okay, so some other key formula in autoimmunity. So Miki is it's kind of like the MIT version of mesalazine. So it's really anti-inflammatory in the gut. So if we see high T helper 17 cells on the lymphocyte typing, often we would put in Miki, or if they have IBD. And then we've got specific remedies set for MS, blood-brain barrier dysfunction, defective immune response or inflammatory reaction, central nervous system lesions or degeneration. PR we can use specifically in rheumatoid arthritis and PSO in psoriasis. So MIT, you have these two options really. You can work empirically if someone, say, doesn't have the funds to do the testing. So we have these remedies, we can say, let's just give you this remedy based on your history, but best is always to do the bloods if you can. Just an idea, you can find all of the studies on micro-immunotherapy.com, and actually if anyone's interested in doing the training, you can go by there as well. So just to give you an idea, just some specificities of MIT. It's really, really well tolerated, so that's why I get a lot of people referring to the clinic for MIT, because they're just not tolerating anything else, and the practitioner there's nowhere to go with them. So this gets really well tolerated and can start to nudge the immune system in the right direction. But part of my work when I'm seeing someone and assessing them for MIT, with my quite lengthy experience in integrative medicine, is to also make sure that we're turning over every stone. Think again about the bricks weighing down on the immune system. Have we looked at everything? Has the psycho-emotional really been addressed? Is it being addressed? That's so huge. Has toxicity really been addressed? Has nutrient deficiency in the gut really been addressed? So, if we have this huge burden and we're just giving this nice little MIT support underneath, it's not enough. So we always say MIT works really best in conjunction with other integrative medicine approaches. So it's sublingual, it's sweet, a bit like the homeopathy. It's like little sugar globules that the remedy is infused into. The reason I say that is quite nice for kids, they quite enjoy taking their MIT. Just goes under the tongue and dissolves. Safe in babies, children, the elderly. In first and third trimester you can't use it in pregnancy, but outside of that you can. Breastfeeding, no specific clinical studies, but it has been used widely with no problem. There's a tiny bit of lactose in it, but actually I've got a colleague who's anaphylactic to dairy, and she took it and she had no problem, so that was brave. But yeah, no problem. Can't do it in organ transplantation. We were talking at lunch, weren't we? So yeah, not in organ transplantation. And you do need to take it away from food and drink, because the activity is here. So 20-30 minutes either side of food and drink. So it can't just be knocked back with all your normal supplements. That's the only kind of downside I would say with MIT, is just fitting it into your day around your food and your supplements, just trying to find the right time. And they have to be taken 2 hours apart, so each remedy. So you're on maximum 4 remedies a day, and 2 hours apart at least. And the last one ideally before 6. Although there is one called Sleep Reg as well, which is a very handy one for people whose circadian rhythms are really out of balance, and they just want to take something to help them sleep. So it helps to kickstart their circadian rhythm and get them sleeping better again. That one you take just before bed. Okay, and you can take it with everything else as well. Okay, so I think I said already, can be done empirically or best done with a blood test. So this is what the lymphocyte typing looks like. Yeah. T cells, B cells, natural killer cells, we do the viral serology like I mentioned, inflammation profile and T helper cell typing. It goes for German lab, 3-week turnaround time. So here you go, here's my very grateful patient. So he was my first ever MIT patient, rheumatoid arthritis, and bless him, he was actually the landlord of the venue that I was room renting from in clinic. It was when I was working out of London that time. And he said, oh, I heard there was a new doctor on the block, I just thought I'd come and check you out, see if there's anything new on the cards for rheumatoid arthritis. I've had it for decades, and I'm a mechanic, and basically he was drinking 7 lagers a day just to get him through his pain, and he would do 1 minute of work and 20 minutes of rest. And then, literally within 3 months, he was doing 20 minutes of work and 1 minute of rest. And he had gotten his alcohol intake down dramatically because he didn't need it so much for the pain relief. I mean, there's probably a bit of addiction in there too, but you know, he was self-medicating. But yeah, his was a really interesting journey actually, because he found out, you know, through our journey together, and as his symptoms started to calm down, other things became apparent. And he one day just sent me a video of himself approaching his TV, and he said, look, I'm really weird. Whenever I go near my TV, it crackles and turns off.
What?
Yeah, I know, that's what I thought. And so I did a bit of, you know, looking around the subject, and I had some specialists in the electromagnetic hypersensitivity field, and I said, could this be a symptom? They said, yeah, actually it can be a symptom of EHS. And so he really went down the electromagnetic hypersensitivity rabbit hole and joined all the forums, and he got the meter, and yeah, he just found he was so highly electromagnetic sensitive that you know, when we started having Zoom calls, he was like 2 meters from his laptop. He'd really learned that, you know, he was just super sensitive. And then underneath that is actually metal toxicity. So, you know, the metal toxicity linking in with his EHS. So he's a fascinating case study. But in terms of the MIT, within 3 weeks, you know, he wasn't one for massively changing his diet. I tried to do a bit of psycho-emotional, some visualization. He just like almost laughed at me. He was just so not up for any of this stuff. But the MIT, yeah, he was just, that was my first MIT patient. I was like, this stuff's amazing. So obviously they're not all like that, but that was a great study, great case study.
Is 3 weeks your typical to see results?
Yeah, I would say so. I mean, his was dramatic, yeah, but quite often they will say, you know, subtle. They'll start to say, yeah, I just feel a bit better in myself. My energy's a little bit better. Yeah. Okay, so yeah, so the way that we work is, you know, what I'm wanting to do is really build trusted partnerships and alliances with other clinics. So it's not saying refer your patients to us and, you know, and we'll take them over. Actually, we want to work with nutritional therapists, psychotherapists, functional medicine practitioners. You keep hold of your patient, but just refer in just for this service, the micro-immunotherapy. And then quite often in micro-immunotherapy consults, you know, they'll bring up other issues, and then we will be liaising with the practitioner and saying, you know, have you thought about testing this? Have you thought about testing that? So there's a learning collaboration there as well. And because we like your initial consultation notes, because it saves time for the patient, saves them a lot of money as well. They don't have to come and do a full like £550 initial consultation, 1.5 hours on Harley Street. You know, this way they can actually just give us your initial consultation notes, you get a referral fee, and then we'll just do the MIT part for you, and then, you know, work in conjunction. So yeah, so this is if you want to, you know, you can just contact my PA just to refer someone. Simple as that. And I think that's it. Any questions?
For those of us not in Europe, where can we get MIT therapy?
In Europe?
No, not in Europe. Anywhere else but Europe.
Ah, I see. Don't know. Sorry. I mean, like I say, it all kind of has come from Germany.
Yeah.
I mean, we order it from Dublin, Ireland, so they get it from the Germans, I think, and then ship it over to mainland here. So, yeah, no answer for that. Sorry.
I'll ask the Germans.
Yeah. But if you go to micro-therapy.
Yeah, I saw
it.
Yeah.
Ask them. They're the ones that will know.
So thank you, exciting talk.
Sorry.
I want to ask, I'm sorry.
That's okay.
I wanted to ask about cancer patients in remission.
Yeah.
Do they benefit from MIT? And how do they benefit from it?
So we have specific remedies for cancer, actually. It's a whole other presentation. So for solid tumours, it's C1, for CLL, it's CL1. You know, we have lots of different remedies according to what type of tumour we're dealing with. I can't say there's really solid data around it, because I asked recently for a cancer clinic about to start working, you know, to see if it can be accepted within the mainstream. A studies, but probably not to the standards that we want. But yeah, we do find, because it's working through the SNAs, it's working specifically at the level of oncogenes as well. as well. And when you test the lymphocyte typing of cancer patients, you do see quite a lot out of balance, and you work according to the results as well. But the nice thing is you can use it when they're on chemo. The only thing that you can't really use it with is high dose steroids or specific immunosuppressants.
No, just if you ever use it for asthma, if you have any asthma patients.
Yeah, so often we would be alternating between allerg and inflam, because you're looking at histamine responses as well. So those two work really well in conjunction. Allerg is a standalone formula, so you have to use it on its own. You rotate it with inflam. But like I say, you can work empirically. And with kids, we work empirically all the time because they don't want to have their blood taken. And actually they respond so well, a bit like with homeopathy, they respond really well to these lower dose remedies. But really it's best to, even though it's asthma, get the blood taken, see exactly what's out of balance and work with it that way. At the same time as turning over the stones and see what's driving it underneath.
Thank you for your presentation, very interesting. I have some questions if it's possible. Can you tell me please, that is like synonyms for exosomes, cytokines, is the same or not?
No, not the same.
It's not the
Not
same.
the same. No.
And the second, for trichology, you have some experience to treat the patient with trichological problems.
Yeah,
Alopecia may be very serious.
it depends on the cause, doesn't it? So, if it's pathogenic, then you need to look at the pathogen, and then what you do the gut work, see what's sitting in the gut, if there's fungal overgrowth, etc. as well. But at the autoimmune level, yeah, this can be really useful, absolutely, yeah.
Yes, we have heard a lot about pathogenesis. So everything that we have